Hello, my name is Crystal Davis, and I joined the rare disease community back in 2011 when our youngest son, we have 5 children, was diagnosed with SMA type 1. And you'll see that that's relevant to today's discussion. I wanted to be there with y'all. This was going to be my first trip since we locked down for the pandemic, but with the new variant, I didn't feel comfortable. We actually lose most of our SMA patients to respiratory illnesses. So if you have any questions, since you can't reach out to me in the halls or anything at the conference, please feel free to shoot me an email and I'm happy to jump on a Zoom or schedule a call. And I founded Texas Rare Alliance to help improve access and health outcomes for nearly 3 million Texans living with a rare disease. So SMA is actually a really good case study when you're looking at EAPs. We have at present 3 approved therapies, and we've had 3 expanded access programs. I typically, when I'm talking about the therapeutics, I'll discuss them by the type of therapeutic, and I won't use their name. However, because we're actually looking at the specific EAPs, I'm going to refer to them by name today. So the first treatment in EAP was SMNRX, which became nusinersen and is now known as Spinraza, and it's an antisense oligonucleotide. And then the second is Zolgensma, which is a gene replacement therapy. And then we have Evrysdi, which is a small molecule. So not only do we have 3 different expanded access programs, but they're for very different classes of treatment. So we have 2 that were under CDER, and then we have the gene replacement therapy that is under CBER. And the initial experience with SMNRX was pretty frustrating. When our son was diagnosed at 8 weeks of age back in at the end of September in 2011, we had a clinician reach out to ISIS, the biopharmaceutical company at the time, to pursue access through compassionate use, and we were advised that there would be no compassionate use. And when you look at these smaller companies, that's really not that out of the norm. They just don't have the resources to manufacture extra product, and then also the logistics of running expanded access programs. But we are seeing an uptick in a number of contract organizations that will do that for them. So we do hope that that will change in the future. And it was also interesting at that time because it was already ongoing at that time, but really it kicked off and through probably 2016, there was a really big pursuit for right to try in the states and at the federal level. And although this did not result in any patients accessing treatment early, what it has done is resulted in significant EAP reform. And one thing that the FDA did early on was they really shortened the application form for EAPs. And I believe it took over 10 hours for a clinician to complete that form, and now it takes minutes. And now when companies are participating in, or when they have clinical trials that are ongoing, they must disclose their EAP policy on their website. And so the patient communities can actually know where the company stands and what its position is. So our pursuit of an EAP for the SMA community started back in 2016. On May 4th, we met with the FDA in a closed meeting, and we had several asks. We asked that they stop the placebo trial, that they provide a means of early access pre-approval for the weakest SMA patients, which are the type 1 patients, that they approve the treatment early, and that they approve the treatment for all SMA patients. And this is really the core group of the FAST movement, which is a group of moms that I was proud to be a part of that went to this. And I want to point out that there are really, there's only 3 of the moms that have type 1 patients. And so it was very humbling that these other moms were willing to ask that pre-approval, the weakest patients get access to the treatment. So the Spinraza EAP really happened quickly. We had that meeting with the FDA on May 4th. Dr. Woodcock requested an interim look into the data. And I believe in July, they announced that the primary endpoint had in fact been met, and Biogen exercised its license for Spinraza. And so this is when it was really a pivotal moment, because now the ball was in Biogen's court. They had substantially more resources and could really kick off that expanded access program. And that went live on August 12th of 2016. And it was available to SMA type 1 patients, and they were, as long as they were under 18. However, the participation was restricted to the 12 trial sites. Initially, we thought that this would be a good thing and that we would see sites coming on quickly because they were already dosing patients. However, that wasn't the case. In fact, 4 of the sites opted out, didn't treat a single patient. We still saw a lengthy IRB process to get these EAPs going at the sites. And we really didn't see that many patients treated, except for at a couple of sites. We were at the St. Louis site, and we did a lot of legwork there. We did a lot of memorandums, emails, phone calls. We had a couple of face-to-face meetings. We talked about the IRB and what the hospital had done in the past that would open the door for it to really participate and be a leader in this EAP. And so it was by no means a sure thing. And at the beginning, it looked like even St. Louis Children's was not going to participate. And if it was really going to stick to the initial trial inclusion-exclusion criteria. And that's really not what an EAP is for. So there was a lot of frustration. And depending where you were in the US, it was even hard to get on the list to some of these sites because they still didn't want you to be too far away. Many of these babies and children are medically fragile, and they didn't want babies and children to be lost in the process, to die because they were compromised during transportation. So there were a lot of concerns. We're very fortunate in that our son Hunter did participate in the Spinraza Expanded Access Program at St. Louis Children's Hospital. I know you can't probably read his shirt, but it actually reads, "Thankful for Spinraza." And I believe he received his Spinraza injection, that initial one, on Monday, the day before, or the Monday on the week of Thanksgiving. And so we certainly did have a lot to be thankful for. And the next treatment for an expanded access program was Zolgensma, the gene replacement therapy. And that was a managed access program. And it's quite different in that it was a patient specific. And so you really had an attraction, and the access champions really stepped forward to pursue access for their patients. So you still needed the institution, and doctors really went to bat for these patients. And the requirements, they were SMA with 3 or fewer copies of SMN2, and SMN2 is the backup gene that replaces provides some functional SMN protein, which is what causes SMN, or SMA is the lack of that. However, with Zolgensma, because it's a gene replacement therapy, it does not rely on that backup gene to work. And they still had to be infants, and there were weight restrictions as well. One of the hospitals that stepped up to participate was Dell Children's here in Austin. I had since moved from St. Louis to Austin, and here we have some fraternal twins that were treated in the managed access program. And this is a picture of them back in 2018, shortly after they received the gene replacement therapy under the managed access program. And the father said, "In the last month since our babies received gene therapy, we have seen incredible improvements and changes in their condition and strength. With a diagnosis that typically progresses towards death, they just turned 1 year old and are thriving, happy babies." And so the Carter twins, I'm happy to report they're still doing well. I recently saw a picture of them on Facebook where they were riding on little ride-on cars, and I've seen them in their walkers walking up and down their driveway. So this is, it's really, it's mind-blowing to see how much has happened in our community. One of the exclusion criteria, I didn't include that, was for tracheostomies. And you can see that the brother, the fraternal twin, actually has a tracheostomy, and he's on a ventilator. However, they were still able to access the managed access program. And so one of the things that we still do, although maybe don't get your hopes up, is that you can still apply even if you may not meet one of the exclusion criteria, and who knows. And I've also seen this baby. I've not seen him. He's a toddler now. I don't see him on his ventilator. So he is breathing on his own now. And the final expanded access program is risdiplam, and it is a small molecule. And this is really geared toward older SMA patients where Spinraza and Zolgensma, especially Zolgensma, you had to be an infant. But this is for patients who were still not on a treatment, or who were not doing well on their current treatment, and could have their doctor apply for them to cross over. And so under the EAP, the patients had to be 2 months or older, and they had to have SMA type 1 or type 2. And this is patient specific. And this really opened the door in terms of expanded access, because it is not reliant upon a site participating at all. As long as the clinician was willing to fill out the expanded access form for the patient, then they could pursue expanded access. And then I just wanted to go over some expanded access thoughts that I've encountered in speaking with others. We've really gotten the FDA CEDAR and CBER perspective. I know I talked with Dr. Woodcock at an expanded access conference where we both presented, and we were just both over the moon that the SMA community had 3 approved treatments and 3 expanded access programs for those treatments. And especially when you have a condition like SMA, where it is life-threatening, when you have a clinical trial ongoing, you have patients, you'll see petitions to access the treatment. You'll see pleas. You can just feel how desperate the patient population is to access these treatments. And I don't want to discount for those conditions that may not be a terminal illness, because still, if you have a condition and there's an unmet need, and there's a disease progression, then still that's the worst thing that the patient or the patient's family has probably encountered. And so you'll still see that on that side as well. I think that oftentimes the media uptick is probably not as high as it is with those conditions that are terminal. And then I also wanted to put out there for consideration, what about patient funding? So we've seen that even in the SMA space, we'll see that a lot of the seed funding for the research will come from the patient communities. And I know that Cure Duchenne is at the conference. And when you have patient advocacy organization, venture philanthropy enter the picture, now we know that they're not just handing over funds with anything in return. So I wonder if we're going to see some type of contracting for the pursuit of expanded access program. And then we've seen in the last year the attack on accelerated approvals since ICER joined MACPAC. And we've already seen that at the federal level, and we're anticipating that to trickle down to the state level. So really, the goal is for them to reduce the reimbursement on these treatments with accelerated approvals. And part of the rationale is that they're reaching segments of the patient population that were not even included in the trial, and that also the trials didn't run the full length of a typical clinical trial. And so accelerated approval is one way to reach the additional segments of the disease population that the company would seek to reach upon approval. However, what we're not doing is we're not doing a good job at capturing the patient real-world data. And I think that if we had ways out there and presented them to the patients and the caregivers for them to monitor the patient on a daily, weekly, whatever the case may be, basis, that you'll really see that participation, because they understand that continued access is oftentimes contingent upon providing that real world data. And I do believe that we will see a shift at some point from even certain segments of data to really patient-specific data for reimbursement. And I think that may be what we need to do to escape some of these artificial metrics like the quality. So I want to thank you for tuning in today. And if you have any questions on any of these, please reach out to me. Again, I'm with Texas Rare Alliance, and we are making Texas a state of access for nearly 3 million rare disease patients. So I will go back and I don't know if there are any questions. If I can look at that, I will certainly go to the chat and see if there's any questions here. So I do know that I recently received a call from one of the US representatives, and she indicated to me that she was considering revisiting Right to Try. Um, I don't really know the full context of that. We didn't get to go into that conversation very deeply, but I would suspect that one um, one of the results of that would be to further broaden the expanded access and its reach to patients in the rare disease communities. Yeah, so the attack on accelerated approvals really goes on to the long-term efficacy and the efficacy in the among the different types of segments of the patient population that may not have been included in the robust arm of the clinical trial to secure approval. And so I do believe that when we start taking that real world data and providing the patients and caregivers a means to track that efficacy and then go back to their clinicians and have that match up with the clinicians' observations as well, then you can get a data trend. And then you can trend that data by the patient, and you can take data snapshots to see when the patient's really improving, or with an illness, maybe they have some regression, but we're not doing a good job of that. So I just think that by engaging with the real world data, having it there, connecting it from the patients to the clinicians, and the expanded access program, and even post, I think, even post approval, I think in commercial access, I think ultimately, I think that real world data is really going to play significantly into reimbursement for these products. Okay, well, I do not think that there are any other questions. I want to thank y'all for tuning in. And again, if anything pops up, thank you. How are the patient advocacy groups working with, with manufacturers? I think that moving forward, again, for real world data, yeah. So we have to have a means to capture it, and a standardized means. I think that we are seeing some apps. They're primarily utilized in the clinical trial itself, and they haven't been really rolled over to the expanded access programs. So they may not need to have everything there for the clinical trial in the EAP. However, if they trim that down and provided that to the patients and caregivers, then I think that they would be surprised at how many would actually participate. And especially when we do a better job at educating them as patient advocacy organizations, the importance of real world data and continued access to these treatments post commercialization. So I do think that it is on the patient advocacy groups when we're talking about with them about the trial design. I think when you're talking about at that time, go ahead and raise the expanded access. If you're an organization that wants one, put that out there, and put that out there that you also want a mechanism for the patients and caregivers to collect that real world data and to trend it that they can see over time. So it's actually beneficial to them and the clinician as well. Thank you so much. It was a pleasure to be here.